This is interventions part 2. So I have a lot of asthma patients that are poorly controlled. Poorly controlled means that a patient is using their asthma inhaler more than 2 times a week. Their emergency inhaler I'm talking about, their albuterol. Albuterol is a short-acting beta agonist. It's beta 2 selective. Beta 2 is on the bronchi, beta 1 is on the heart. When you use it a lot, you lose selectivity. So you do have tremors, increased heart rate, sort of side effects from overusage of that. So I have some patients that are picking up 1 or 2 inhalers every single month. They're using it like 4 times a day, every single day. Poorly controlled is when you use it that often and you're not using it like preventatively, like before exercise. It's because you're actually having an exacerbation. So asthma per GINA guidelines requires a steroid inhaler for maintenance. Right now we use SMART therapy, single maintenance and rescue therapy is what we use. So we use Symbicort. It can be used as needed and as an emergency. It's because it's a combination of drugs, and the long-acting beta agonist, the formoterol, has a fast onset. It has a faster onset than, say, salmeterol, which is an Advair. So that's sort of the pharmacology behind it. But when you do use a lot of albuterol, you can also get hypokalemia, meaning you can get lower than normal potassium levels, which is not a good thing to see. So what I do is I send notes to the provider saying patient's poorly controlled, they're picking it up every month, please send in Symbicort inhaler per GINA guidelines. Sometimes it's not covered, but I navigate that with the provider to make sure I'm recommending an inhaler that is covered. So I can do a formulary check and do that for them to make it a little easier for them. All Medicaid formularies are readily retrievable online, so the provider can do that on their own. But for commercial plans, it's easier for me to run a formulary check. Another intervention I make is my patients who are first-time opioid users. We call them opioid-naive patients. This is when patients have an acute surgery, they're sent a prescription, they come to pick it up. I've had a lot of patients picking up opioids at too high of dose. I've had patients sent over Percocet 10 milligrams when they're supposed to be getting like Perc 5 or hydrocodone 5 oxy and Percocet. Those are more potent than hydrocodone and Norco and Vicodin. So it's important to use your clinical judgment when you're prescribing and dispensing these medications. So we tell potency of an opioid by morphine milliequivalents, MME, which is a generalized sort of like scale that tells us how potent is this, how much of this opioid they're getting a day. So when you're above 60 MME, you need to recommend Narcan to a patient. When you're above 90, you need to use professional judgment. I've had a lot of patients sent over acute opioids well into the hundreds MME. So I counsel them to split the tablet, and I recommend and dispense them Narcan per standing order.